Okay, so we might make a start, and other people will join us as we run through. So, welcome to the webinar, which is part of the Community Practice in Implementation Science, sponsored and funded by the Cancer Institute New South Wales. This is part of an ongoing series, and we thank you for joining us. I'll just start with some housekeeping before I introduce Helen. So, as usual, we're going to have participants muted during the presentation, but we encourage you to put your hand up after the presentation, and we can either have you actually speak if you have microphones and privacy to be able to do that, or you can type your questions into the question box and we can read the questions out to Helen. So it's with great pleasure that I introduce Helen Crisp from the Health Foundation in the United Kingdom. So I've had a number of interactions with Helen, often asking her to do things like this, which is a good trooper to take part, and I really appreciate her doing that. So I think Helen, I've been particularly interested in the work that Helen's worked on in the UK, I think particularly because of the approach that Helen's taken to improvement science and the crossover between the quality improvement and implementation science, which I hope we can talk a little bit about perhaps after the session or maybe during. And obviously, so just to introduce Helen in terms of what her role is now and what it's been recently. So Helen's responsible for managing, she's Assistant Director of Research at the Health Foundation. So she's responsible for managing the research grants and commissioning team at the Foundation. So working with major academic centres on research into quality improvement, value for money and organisational effectiveness in healthcare. So dispersing around £3 million a year of research funding. I think this is something we actually lack in Australia is a foundation such as this, and I think it's something worth considering. Obviously, the Cancer Institute plays some of that role in the oncology space, but I don't think we have an equivalent within Australia of the Health Foundation itself. So Helen's also coordinates the Foundation's Improvement Science Programme, and I've heard Helen present a number of times at conferences on the work that the Foundation supports. I think it's very interesting how the Foundation actually engages with some of those processes and how that actually is rolled out as a funder, as well as actually taking an active part in the studies. So Helen's also worked as a healthcare quality improvement consultant and developing quality standards for health accreditation programs and benchmarking, and worked on a wide range of projects in the United Kingdom. So Candice, I will just hand over to Helen now, and then Helen can take over. So I'm going to step back now and we'll hand over to Helen. But as Helen's speaking, please think about questions you might like to ask and start typing them in as she goes. Thank you. Right, so Helen, I hope we've successfully handed over to you now.
Okay. Well, I hope people can see the screen and see my first slide up there. So I'm going to be talking about getting inside the black box of quality improvement interventions. I just want to start by telling a little bit about the Health Foundation. So as Tim said, we are a UK charity, and our mission is to improve the quality of health and healthcare. And we're in the very fortunate position of being an endowed organisation. So we have an endowment fund, and this enables us to fund improvement programs, to test innovations. We fund a program of research to build the evidence, particularly it has been today around improving the quality of healthcare, but we're now moving into the areas of healthcare policy and improving population health. And in those areas, we also fund programs, leadership development programs, where we offer fellowships and leadership programs to a wide range of individuals working in health and care services. So this, very briefly, is what we want: better health and healthcare, and working in these three areas to improve health service delivery, to make health policy making more effective, and a healthier population in the UK. Our funding comes from funds that were generated in the UK, and by our charter we can only make grants for activities in the UK, but obviously our research and all of our resources are available to people internationally. I'll mention some of those and they're all available to download from our website. So over the past 5 years, the Health Foundation has been sort of particularly active in looking to develop improvement science. And that is because we believe that to improve the quality of healthcare, the improvement work that people are doing needs to be more scientific. And whilst this movement has been going for about 20 years now, effectively looking to improve particularly patient safety in healthcare, but also approaches to more person-centered care, approaches to have evidence-based medicine, approaches to increase the value of healthcare services. To date, there's been quite a weak evidence base for improvement methods. What evidence there is often contested. I'll be talking quite a bit about design of interventions and how those are put together, how they're described, and how results are reported. And all of this leads to this rather weak, patchy implementation. We get lots of projects that work here, projects that show some good findings there, but it seems to be very, very difficult to get improvement efforts that are really shown to be robust, that are shown to be implementable at scale, and that are really making a difference to healthcare at the sort of level that we would aspire to making a difference. So we've really been thinking about, well, how can we build this research evidence? How can we make sure that the evidence is better used to support improvement? So that's what we've been very involved in. And the black box problem is very much integral to this. So as we've said, for many interventions, although they appear to be successful, the evidence is limited, and people don't necessarily understand what was done, how was it done, how could it be reproduced. And so it's been seen to be this sort of problem at the heart of a lot of effort going in, a lot of work, a lot of really committed people, but unfortunately not really delivering the results that we'd hoped for. So we're going to be exploring this a little bit more in this webinar, and particularly looking at these sort of 4 areas which can in many ways help explain what's going on, what's not going on, and how we could, as it were, improve the improvement effort. So looking at how is theory used, how do people understand the interventions that they are both developing and those that they try to pick up and implement from elsewhere. If you have an intervention, what really are the core components of that? And because we don't understand any of the first 3, there's often this difficulty of replication and spread, and very often the context is cited as one of the problems as to why we can't get these things to spread. So let's start with what I'm calling facet 1 of the black box, and this is a cartoon that you've probably seen presented before. I haven't used it myself, but I do like it. So we had an idea for an improvement intervention. We tried it out and we got these results. But there is a missing bit here. There's a real lack to the explanation as to what has happened. And this is about what is the theory for the intervention. And there's 4 key points there, which I've lifted from the article, which is one of the handouts for this session, published earlier this year in BMJ Quality and Safety, Demystifying Theory and Its Use in Improvement. And really this whole webinar draws very heavily on that article. So what Davidoff and co say about theory is that its role and value is under-recognised in improvement work. And I think this is very much about the sort of people who take up improvement, they're activists, they're doers, and they sort of tend to glaze over at the idea of theory. And so it's under-recognised, and people are not aware of what theory they're using, or certainly don't make it explicit. I think what the article shows and what we know in general life is that people are actually acting on theory most of the time, but it's about being explicit about why do you expect these actions to lead to these results. And we need a theory because we can't just go with personal intuition that it seems like a good idea. as not going to sell it to other people. And so where we have formal theory, it really helps to build the evidence base and enable this exploitation and spread of the knowledge, and with the knowledge having some credibility and having some scientific credibility. So being more explicit in step 2 is really about developing a theory of change for the intervention. So this is a very simple one, which says if we do some things that are part components of our intervention, then we think these actions will happen so that some of our more high-level goals are reached. So this is very simple. This is just about shared decision-making. If we had consultations designed around discussion and patients are given information in advance, then that would help. That there'd be a causal link between the design of the consultation, the fact that people have got the information, as to how counselling becomes part of the delivery, how that would help patients increase their skills and knowledge, so that there would be genuine shared decisions and a belief that if there's a shared decision about the treatment, then it's more likely that people will stick to it. So this is a very simple expression of a theory of change. There are various models and tools, many of them much more complicated than this, that really seek to show the causal links between the components of the intervention and the goal, the actions and the goals. But all of these approaches are about having a systematized way of thinking about and making explicit the links between what is happening in the intervention and why you think that that is going to lead to achieving your desired goals. So, facet 2 of the black box, is it actually clear what the intervention is? Could others reproduce it? And I, for example, just before doing this evening, I was just reviewing 50 articles to understand whether they were going to be helpful in providing some evidence for a project that we're doing. And several of those articles were very, very vague about what was the intervention. It just said it was an intervention to increase patient activation, but no description of what was really done within that intervention. So we often find the description is limited to just the surface appearance, or we're doing a flow project, but with no details on the mechanics, on the methods used. And this, in the world of clinical trials and RCTs, would be the equivalent of saying we gave the patients a small white pill and thinking that that would be sufficient science for people to have credibility in our results and be wanting to take on our small white pill and give it to their patients. So we do have to be really careful of what has been called cargo cult improvement approaches, and this links to particularly the work of Richard Feynman, where he described cargo cults and described it as being akin to some science working in the same way, that people on the South Sea Islands, particularly during the Second World War, saw that the planes arrived and that various material goods followed when the planes landed on their islands, and after the end of the war sought to build their own planes, so the surface appearance of what they saw happening, but not understanding the mechanics of how this was manipulated, how did the plane landing result in the goods being delivered to them. And so they build their version of the plane, but the goods don't arrive. And we do see this in improvement science. So having seen something that appears to have been successful somewhere else, we'll call it flow project, or they used big room, and we'll get some data on length of stay and cost, and that somehow or other this is going to reproduce what another organisation has done to manage to successfully improve patient flow through their organisation and to make sure that care is more effective and that they've reduced the length of stay. But unless we really understand all of how that was done, it won't be possible to reproduce it. So this is particularly important when people are writing up improvement interventions. And we do find articles that mention or used PDSA. Well, you know, PDSA is a technique. You need to know what was planned and done. How did you study it? What were the results of that study? And what action was taken in response? Not just 3 rounds of PDSA were done. So we need to know why were these methods selected to tackle the problem and exactly how they were used. We also know that, you know, nothing really works first time in healthcare, that improvement, interventions and designing one and developing something always tends to change. It needs modifications along the way, that there are challenges in the organisation, in the way that the method doesn't work the way you thought it would, the way some groups of staff are very resistant to the change. And so we need to know what were those challenges and how did you need to overcome them, what changes were made in response. And measurement, we're always talking about how important measurement is, you know, that results need to be reported. So we need to know what the suite of measures were, but also how they were defined, how they were collected, how easy or difficult it was to collect them, what method was used for analysis, and also being really clear about how that data then links to the conclusions. Again, and you start reading a lot of papers around improvement work, there's sometimes some very odd logical leaps made between what the data results are reported and how people then assume that that supports their conclusion. So as well as the methods used, the measures and so on, it's very important to think about what are the active ingredients, the core components of the intervention. And again, it's often very sketchily described and even sometimes poorly understood by the people who are running the intervention, because everything that you do in healthcare has some specific elements of content. The service delivery issue to be improved, you know, what was that? And don't assume that some vague description of this will make it understandable to other people outside your organisation. The area of clinical care has a huge impact on what you do and how you do it, as does the patient population. And if something has been effective in one setting, it's really important to know what were those core elements, how they interact, and which are essential, and to think about it a bit more. We're always saying that in order to spread improvement interventions, they need to adapt. Healthcare is very complex. Each organisation and healthcare system is different. The intervention's got to have flexibility, and we've got to know how to adapt it to meet a new context. But we've also got to understand the difference between what's amenable to adaptation and what must be retained. So, for example, if we want to run a new style of COPD clinic and really want to get patients involved in their care, and the intervention that we're seeking to reproduce is called the Monday clinic, that doesn't mean that it has to be run on a Monday. Probably the new style is about where was it run, and in this instance, it was a community-based clinic, so it was about taking the service out of the hospital and into the community. But then there are also things about who ran the clinic, and investigating this further, the team who've done the original intervention are now seeking to spread it. They've changed their ideas about whether that's adaptable or not. They started off thinking it wasn't adaptable and it was really important that the hospital consultant went out to the community, but now that they've tried it in a few different areas, they're realising actually that can adapt, that clinical nurse specialists can leave the community clinics, that GPs with a special interest can leave the clinics, and that there can be lots of combinations of people who can leave the clinic. But one of the key things about it is that it's about going to where patients are and where is it easy for patients to go to on a regular basis and not expecting patients to come into the hospital. Likewise, there's a lot of elements around successful training that we really need to understand, you know, what has to be in place, or are we really not reproducing the training that has been successful elsewhere. So we very often get the content and people have their training materials, but they may not be clear about who delivered the training or how it was delivered. So for example, if on further study you find that actually the key part of the original way that the training was delivered was it was into multidisciplinary teams, then you're not going to get the same result if you start running it somewhere else you start running groups separately for doctors and for nurses and for healthcare assistants and so on. And so these are all about what must be retained, what are the core active ingredients of our intervention, but also moving on to our next facet, how do they interact with context within which this improvement intervention is playing out. So there's definition of context there, the why and when of change, and the idea is external context and internal context. And this is constantly cited as one of the reasons as to why it's difficult to reproduce improvement interventions, because the context was different. So we need to really understand, you know, are we in the right soil for what we're trying to do? If we're trying to reproduce something from sort of a lush, fertile, arable land, it won't really work in our stony desert. And that would be wasted effort, excuse me, to try to reproduce something in totally the wrong context. So they've got some facets of external context. You can't change those, but it's important to know what they are and how does your intervention align with those elements of external context. And likewise, within the organisation, what's the leadership, what's the sort of support from the leadership for improvement? Is the leadership very stable? Are they up for change or not? And that may not be about continuity. That may be about how much is happening in the organisation. Does it fit with the organisation's vision and strategy? So, if your organisation is committed to integrated care and getting the services out into the community, you're going to have a lot more likelihood of getting your community COPD clinic with top-level leadership support. If, on the other hand, you're in a healthcare system where the hospital feels threatened and their income is threatened and they don't have good relationships with other providers, this may not be the current direction of organisational travel. And there's also the idea about what sort of vision has the organisation got about improvement projects. But I have heard people proudly proclaiming that they've got over 300 improvement projects in their organisation. And I think we have to really wonder whether that's a very helpful context for interventions that are really going to spread and flourish. So just many of the different sorts of aspects of context that need to be considered. And this is the other handout that was circulated with the details of the webinar. And again, that's also available to download from our website. And the website address is www.health.org.uk. So, in terms of how we can help to open the box, some of the things that are very helpful are reporting guidelines, which have been developed by people working in these areas to try to present some checklist of points to consider and to have some prompt questions. And one of these that's particularly relevant to quality improvement are the Squire guidelines, which have just been updated and reissued. And there are plenty of other guidelines, and the Consort website has information on guidelines. And although many of these have been primarily written as guides for writing up and getting published, they're also extremely useful to think about what are the elements that you need to consider when you're planning an intervention and how to make sure you capture the right information as you go along. And there's the address there, or you can just Google Squire guidelines and you can easily access the guidelines from that website. Oh dear, excuse me. So, in terms of opening the black box, those are some of the key elements as to how we're going to get into what's really happening in quality improvement interventions. Think about the theory and also about updating your theory of change as you get your results in. Be very clear about the methods and also how they've been applied. This whole issue of what are the active ingredients and really understanding what must be in place, what can be adapted to different contexts, but also how the active ingredients work together and how if one of them is missing or changes too much, you really haven't got the same intervention at all. And also the importance of context and the interaction of the intervention with the context, and the fact that in this work we're not excluding context. Context is absolutely vital as part of the work. So you have to excuse me, I've got a terrible cold at the moment, and hand over while people ask some questions.
Great. Thanks very much, Helen. I'm sympathetic to your cold. I'm just coming out of the back of one, so I've been coughing as well. But thanks very much for making that through that. So that was really interesting to have that context from the UK. So I encourage people online to put their hands up if they have questions. I think that's a little button, isn't it, somewhere on the screen, Candice, that you can push to do that, or indeed type your questions in. Look, I've got a number of things to ask. I've always been intrigued, Helen, by the way you describe your work as a real blur between quality improvement and implementation science. I mean, I think many of the projects you're talking about are organisations actually looking at doing that work rather than it coming from an more academic university kind of driven environment. And it was interesting. I ran a plenary session at our innovation conference in New South Wales Health last week, and there's about 700 or 800 people there, and I asked how many people were involved in research, and practically nobody said they were. And I said, how many people are involved in quality improvement? And many people put their hand up. In the UK, I mean, is there more of an acknowledgement of people actually kind of working together in that environment? Because I think maybe that's some of the problems. If you have people that don't understand the research doing it, and then people doing the research that don't understand the context, is that some of the issue?
It is, and this is why we've been so concerned about developing this more scientific and sort of academic and research-based approach to improvement. And in many ways, Health Foundation hasn't been alone on this in the UK, because we've had a number of, particularly in the NHS in England, we've had a number of initiatives that are really seeking to link the research, the academic community with the health service practice community around sort of more effective delivery of healthcare, of which sort of the traditional quality improvement is part of that, and also looking at how research can more quickly influence practice. So that would be evidence-based medicine, as well as the sort of adoption of industry and sort of business-related practices around quality improvement. So we've got regional organisations funded through sort of central government, through NHS England, to make these links between academia and delivery of healthcare. Now, you know, that's great to have them there. I think they're still not really sort of penetrating right through the NHS to really reach the front line of organisations. You know, I think that would be a very big ask. I think we are finding there are more links, and for people who are involved in improvement, they're getting much more idea of how they can work with academic partners. So, for example, there's a lot of emphasis on evaluation of new initiatives and making sure that there is academic input and leadership of evaluation of new approaches. And I think that's really had a push one thing it has revealed is there is a huge shortage of people with those skills, with the evaluation skills. But at least people are recognising the fact that that's an important way of measuring change, evidencing change, is that you've got to have researchers on board as you develop these approaches. And I think that's going beyond quality improvement, but it's really building on the work that quality improvement has done to now have a more structured approach to things like, we've got a lot of talk about new models of care. I mean, basically it's integration of services. And there's been a couple of large studies of those which have shown rather disappointing results. And so on this next round, I think it's given even more of a push to make sure that evaluators are involved, not just in a way sort of the does it work or doesn't it question, but very much working with their health service colleagues to influence the design and the way in which people try to go about change, which I think is very helpful.
Oh, no, thank you. I think you're certainly ahead of us in that space. So I think we've got a question from Natalie. So Natalie, we're just going to unmute you. So can you hear us, Natalie? Go ahead. You should be able to speak.
Hello?
Yes. Hi, Natalie.
Yeah.
Oh, hi. Sorry, I wasn't sure whether my microphone would work.
Yep, definitely.
Thank you for that, Helen. I had a question about trying to ensure that your interventions are theory informed. So in a lot of the experiences that I've had, we work with clinicians and healthcare professionals at the sharp end of care, and it's crucial that their input into the intervention development process is there, because they can identify the problems that are most relevant to them and which solutions are more likely to be feasible in practice. But as these intervention ideas emerge, I worry about how to make sure theory has been used to inform these ideas, or whether it's better to retrospectively map this information as it comes through. And I just wondered if you had any thoughts on that.
Really good question, and very very pertinent to how you actually do this at the front line, working with very busy clinical teams. Because on the one hand, you want to encourage ideas, and you definitely we all recognise the experience that people bring about what's likely to work in their context. But I think it is very helpful, and certainly in some of the work that we've been doing, we've become in a way much more bullish about. We pretty much insist that anything that we fund, that people work on a theory of change, and that we need to see the theory of change, and that is developed as they're developing the intervention, and being very clear that this is making explicit the assumptions you have about why this approach is likely to work and why you think it will lead to these outcomes. It really tease out some of the thinking, but also being clear that it's a working document, that it's not cast in stone, but that it's it's a discipline to just test out the thinking, see whether it looks as if it makes sense on paper, but very much to keep coming back to it and amending it in the light of experience. So you're still very much valuing the experience. You're not saying, oh, well, the theory says it must be like this, and therefore you're wrong in what you're doing, but sort of getting that balance, what we think could work, and it's just that sort of that just more formal discipline of really trying to think it through before you put a lot of effort into something, and sometimes you do think it through, it looks great on paper, and then it just doesn't work when you're actually at the sharp end. But I think the fact that you've got a plan helps you go back and rejig it more than if you haven't.
Yeah. I think one of the things I've noticed is that as soon as the problems, the sort of the behaviours you're wanting to change start to come to light with the clinicians as you're having these discussions, they want to get going straight away and almost kind of run ahead and start solving their their problems before you've had the chance to look carefully.
Yeah, exactly right. We found this very much in a patient safety program we were running, which was the whole premise of the program was to improve the reliability of clinical systems. And so we asked the teams involved to really sort of map their systems and identify and really start thinking about where the problems were. And we did notice that in the teams where they did that, and spent quite a bit of time on that sometimes the problems weren't what they thought they were, and so their initial solution wouldn't really have had much effect. And the other teams were really impatient about doing that mapping, and they did jump straight to solutions. I mean, some of those things worked and they were right, but sometimes they didn't, and it did in a way prove the value of actually spending quite a lot of time on the sort of problem analysis and not jumping to solutions. But it is difficult, and as I say, it very much goes with the territory of the people who are involved, who are interested and willing to give this sort of thing a try in the first place. They do tend to be activists.
Yeah. Thank you very much for that.
Thanks, Natalie, and I encourage others to ask questions, although I think we're going to have to give Helen's voice a rest in a little while. But I mean, Helen, I guess I'm interested in something you were just mentioning. Then I was actually at a process mapping meeting with our lung cancer team in one of our major hospitals last night, and clearly it was an early first meeting of looking at what kind of issues we could address, or what were the problems, I guess, not looking at solutions immediately. And I'm intrigued by, within the Health Foundation, how you then make a decision that some of the issues might be worthy of a kind of a research study, whether other than might be just more of a kind of a quality improvement initiative. I mean, do you have a feeling for that? Some of the things you might want to just put a bundle in and fix it. Other things, clearly we can actually put structure around and aim for a publication and aim for a kind of a research program. Do you have any reflection on that?
Ooh, that's very interesting. I think a lot of what we've done to date has been very much working with people around innovations, and we've certainly given quite a lot of funding for innovations. Some of that's been very much at the early stages, and has been very much proof of concept and developing the ideas, in which case it's kind of pre-evaluation. Although people have still managed, have written up their innovation and got sort of publications out of that and involved researchers in working with them. What we are now engaged upon are programs where we are seeking to spread the interventions that have been, that have apparently been successful either within one organisation or within part of an organisation. And I think this is where, in a way, this again is another part of the problem, is about that there's little research interest in spreading things, and you don't get much sort of kudos or points for picking up something that's been successful and successfully reproducing it. So there is this sort of great there's the whole academic sort of publication interest bias to only be interested in things that are innovative and, as you say, worthy of a research study. But we've really got to put quite a good deal of our energy and in terms of what we seek to promote across healthcare into replication. So I think one of the areas that actually needs quite a lot more study is the whole thing about how do you replicate, how do you pick up something, develop, as you say, a bundle, and then look at the successful implementation of that elsewhere. And I think, there's there's an awful lot of research which is very interesting around this. So, for example, we see many studies still on this surgical checklist, and whether that's having an impact or not, and very contradictory findings. So, in some ways you can say, all of this at some level is worthy of study, and in some ways we do want to sort of slightly push against that desire to always be with the new, but equally, there has to be an area of a true research question that you're looking at in terms of studying things that have been very well studied already.
Yeah.
And there's no, we're not in this just to generate papers. And it's interesting, I think even the researchers in this area, even though they have a great academic driver to publish papers, people who go into this area are still really more interested in improving the quality of service and improving healthcare than in actual sort of number of academic publications. It's quite a rarefied area in that sense. You're not going to have sort of very many mainstream academics really focusing on this.
I mean, I think that raises a significant challenge for our early and mid-career researchers that are moving into this space to build careers in that, and that's certainly something we look at. A number of the people on the line today are early mid-career researchers, I think, that are, and there's a number of directors of centres that are trying to establish translational kind of hubs, and I guess it is how we structure them so that we can allow people to get an academic track record that's sufficient to be able to get into that kind of game that you have to get into to be able to move up the careers through those publications and so on. And I think it is a challenge, I think. I mean, I certainly know in the implementation we've done, you don't leap straight to the intervention. You actually suddenly find out you've got 2 years of preparatory work you've got to do before you even get to and through the intervention, which I think a lot of people don't appreciate as well. And particularly people that come from the more T1, bench to bedside, where it's a much more kind of worn path between those two than it is in the space that we work in. But anyway, look, I think if we don't have any more questions, I think, Helen, that's been a really interesting presentation. I thank you very much for that. And we'll let you go and take your voice to bed. I hope you start to feel better around that. So, and I hope, Helen, if other people have any questions, they can send them to us and we can maybe forward them to you for answering. But I think in my head, you've really stimulated a lot of different thoughts around that. So thanks very much. We've had a good number of people listening to that. So, and we look forward to perhaps seeing you in Australia one day face to face.
Yeah, well, that'd be great. Well, thank you very much indeed. It's been a pleasure. I hope you all have a good day. I realise this is the start of your day and the end of my day, but yes, very happy to do that, and we'll be pleased to consider any questions that come in after this webinar.
Okay, thanks very much.